failure management, the timing of invasive coronary angiography. So coming to the main topic, like timing matters, the intervention in heart failure, the heart failure management beyond Lasix and O2, where is the sweet spot and which what we are missing in that. So coming to basic few slides regarding the heart failure, 2 slides. So pathophysiology, like moreover like heart failure burden is of ischemic etiology. Ischemic heart disease is the leading cause of heart failure with reduced EF globally. And 40 to 65% of HFrEF is in Western data. And the Indian register suggests a higher CAD burden apart from the valvular diseases. And the multivessel diffuse disease is common, and microvascular and macrovascular ischemia coexist. So coming to mechanism of LV dysfunction in CAD, acute MI which leads to the necrosis and remodeling, and chronic ischemia which lead to the hibernating myocardium, repeated supply-demand mismatch, diffuse subendocardial ischemia, and microvascular dysfunction. So like not all LV dysfunction is scar. We must differentiate between the infarcted myocardium, hibernating myocardium, stern myocardium, and diffuse subendocardial ischemia. If we assume everything is scar, we deny recovery potential. If we assume everything is viable, we over-intervene. So this is where the timing becomes the biological dependent. So the basic mechanisms of LV dysfunction, and coming to remodeling biology, where the infarct expansion and the neurohormonal activation, LV dilatation, increased wall stress, functional MR, and arrhythmogenic substrate are the which leads to the LV remodeling. So coming to Lasix and O2 are not enough. The missing link is myocardial viability. So viability matters in the heart failure management. So now after optimizing with GDMT, like with 4 pillars, we are often stop diuretics, oxygen and we'll consider for the GDMT medications. But extremely important and frequently missed opportunity is identifying the myocardial viability. So because not all the dysfunctional myocardium is dead. Some myocardium is hibernating, and if we restore blood flow, cardiac function can significantly improve. So this is where the viability guided revascularization becomes the true sweet spot in the heart failure management. So what was the concept based on viability based treatment or revascularization? So LV dysfunction is a mixture of both viable and non-viable myocardium. Only viable myocardium improves after the revascularization. The clinical impact is like improves EF, reduces the mortality, reduces heart failure hospitalization, and improves symptoms. So the key message is not all dysfunctional myocardium is dead. Some is hibernating and salvageable. So coming to basic pathophysiology in hibernating myocardium. So like its definition, it defines like chronic LV dysfunction due to reduced perfusion without irreversible necrosis. So mechanism is stenosis, which leads to reduced perfusion, reduced contractility, and preserved cellular integrity. So in contrast, scar, there is no recovery despite revascularization. So key principle is function can return if the blood flow is restored. So, and the clinical goal is revascularizing the scar improves angiogram, not patient. So, like how to assess the viability. So, in ischemic cardiomyopathy, LV dysfunction is a mixture of viable and non-viable myocardium. So, viable myocardium is alive, but the dysfunction due to chronic hypoperfusion. So, if we revascularize these segments, contractility can recover, ejection fraction improves, symptoms improve, and importantly, survival improves. So, however, if myocardium is scarred, revascularization offers no functional benefit. So, identifying the viability directly determines whether revascularization will help the patient. So, there are different modalities are there for the viability scan. So, like cardiac MRI, FDG PET, lobotomy stress echo, and SPECT. So, cardiac MRI, which is gold standard and which shows the differentiating of the scar versus viability, and FDG PET is most sensitive, which based on the metabolic activity, and the lobotomy stress echo is widely available, and it's contractile reserve. SPECT is like moreover perfusion defects. So cardiac MRI, which is the most powerful tool, the cardiac MRI with LG is the gold standard for the viability assessment. The areas that appear bright represent the scar tissue. The key principle is transmural extent of the scar. If the scar involves less than 50% of the wall thickness, recovery is likely after revascularization. If scar extends 50%, recovery is unlikely. So this makes the cardiac MRI an extremely powerful tool in guiding management decisions. So cardiac MRI is a gold standard one, and which shows the viable tissue, how much is the viability, and what is the improvement of the EF after the procedure. So like FDG PET, which is one of the like sensitive tests, and which shows there the four patterns will be there. Which one is like normal perfusion and metabolism suggests normal myocardium or ischemic stunning in the settings of the reduced contractility. And the second pattern is reduced perfusion with preserved metabolism suggests hibernating myocardium. That is perfusion metabolism mismatch. And the combination of the reduced perfusion and metabolism match defects indicates the non-viable infarcted myocardium. And rarely the reverse mismatch pattern. This mismatch pattern is found where the normal perfusion coexists with reduced metabolism. So like these four patterns are very moreover important for this FTG PET. So which is normal match defect, and the perfusion metabolism mismatch, and the reverse mismatch. So like guidelines, what they are suggesting in the guidelines. So the 2022 AH and ACC, which suggestive of coronary angiography is class 1 indication for heart failure with angina or ACS. A heart failure patient with presenting with angina or ACS, and class 2A with new onset of heart failure with reduced EF with suspected CAD. And the class 2B in stable heart failure without angina. So, and ESA heart failure guidelines, which suggestive of invasive CAG recommends when angina present, evidence of ischemia on stress testing, ventricular arrhythmias, high suspicion of CAD. So consider early invasive strategy when ischemic etiology likely. So AHA and both ESC guidelines recommend that viability assessment in ischemic cardiomyopathy before revascularization decision that shows under like class 2A recommendation. So what suggesting like for the viability based revascularization in heart failure patients. So there the deep analysis in the two trials which based on for this revascularization, which is like stitch trial, which is which had a good follow-up study and all those things. So in this stitch trial with the population involved is like inclusion criteria is the EF of less than 35. CAD is amenable to CABG. Results, there is no early mortality benefit, but there is a significant 10-year survival benefit in at follow-up. So key insights, CABG benefit appears over the long-term remodeling timeline. So the stitch trial clearly demonstrates that CABG improves survival compared to the medical therapy in ischemic cardiomyopathy. The stitch extension study confirmed sustained mortality benefit over the long-term follow-up. So this tells us that the revascularization in ischemic LV dysfunction is not about symptom relief. It's about the modifying the natural history of the disease. So sudden cardiac death reduction was significant in stitch trial. So which shows the survival benefit. So why do CABG work in the stitch? So like it shows like complete revascularization, protection from the future plaque eruption or rupture, and the reduction in the sudden death, and like LV reverse remodeling. So this is not just a symptom relief. So PCI based revascularization, like revived BCIS2 trial, that included LVF of 35%, viable myocardium, and they opted for the PCA plus OMT versus OMT. The results showed no mortality benefit, no improvement in EF, no reduction in the heart failure hospitalization. So like criticism of the revised. However, the most recent revised trial showed that PCA did not improve outcomes in patients. So this highlights a critical message. So not every patient benefits from the revascularization. So patient selection, especially the viability, is the key determinant. So blanket approach is inappropriate, and the blind approach is very dangerous. So what is the criticism behind the revived trial, which show like mostly they involved mostly stable chronic LV dysfunction, and PCI incomplete revascularization in many, on the high quality GDMT is already optimized. So there is a limited acute ischemic population which they included in this trial. And the revive does not apply to the acute acute decompensated heart failure, unstable ischemia, shock, and ongoing injury. So we can go for the based on this blind approach is very dangerous for the revascularization. So which patients we need to consider for the revascularization is like acute heart failure with troponin, how it suggests for us. And troponin in acute heart failure, the elevated troponin is in 40 to 20% of the acute heart failure patient. What is the mechanism behind that is valve stress, subendocardial ischemia, type 2 MI, and 2 plaque ruptures. So when is this, when is it type 1 MI we need to consider in heart failure patients? So dynamic ST changes, new RWMA, rising or falling troponin pattern, hemodynamic instability, these patients need early invasive evaluation. So clinical profiles that warrant early angiography is new heart failure with reduced EF, that in less than 6 months, and RWM in echo, diabetic silent ischemia, electrical instability, cardiogenic shock, and recurrent decompensation despite GDMT. When angiography may not help in the heart failure patient is like long-standing non-ischemic cardiomyopathy, global hypokinesia without RWMA, and severe comorbid burden, advanced CKD with low ischemic suspicion, and end-stage heart failure awaiting transplant. So what is the role of CTCA in heart failure? So we had more pros or like a high negative predictive value and non-invasive, useful in low intermediate risk. So cons is like heavy calcium which overestimates, not suitable in unstable heart failure. So based upon how the hemodynamics and physiological assessment in heart failure patient, is it important in the revascularization, but still there is a query regarding this hemodynamic and physiological assessment. Why? Because like FFR and IFR utility in LV dysfunction, like in microvascular dysfunction often unassessed, high LV EDP may alter the physiology indices, and evidence limited, and clinical judgment is crucial. So what is the missed sweet spot? So like real world pattern, how it works is like normally if any patient presenting with heart failure, which reaches to the physician or like which one reaches to the anyone like who is treating the heart failure, the patient will get admitted for the heart failure, they will give the diuretics and they'll decongest the patient, they'll stabilize, they'll discharge, and CAD is never evaluated. So what happens in the follow-up? The patient after 6 months, either he will present with repeated episodes of the heart failure or worsening, like he may present with sudden cardiac death. So what is the timing hypothesis? Whether too early, like unstable renal dysfunction, unclear diagnosis. When to intervene, like timing hypothesis. Too late, it's remodeling complete scar fix. So where the sweet spot already like fever. So diuretics improve symptoms, oxygen improves saturation, GDMT improves survival, but only revascularization can restore the myocardial perfusion when viability is present. If we don't assess viability, we miss the opportunity to reverse the heart failure. So this is a true sweet spot in heart failure management after stabilization, but before the irreversible remodeling. That's where the sweet spot is there. So at that time, we need to intervene. So what is the advanced considerations like patient with the ischemic HF and with 4 pillars of the medications? So is revascularization still addictive? So CABG data supports yes, PCA data remains uncertain depending upon the selection of the patient. So what is the algorithm shows like, so this is a critical algorithm in heart failure management. When the patient presents with reduced EF, after optimizing GDMT, coronary anatomy must be evaluated. If significant CAD is present, viability testing should be performed. If the viable myocardium is identified, revascularization can improve cardiac function and prognosis. If no viability is present, these patients are better managed with the device therapy like CRT or advanced therapy. So this is a decision point where we can change the trajectory of heart failure, and you can just revert the remodeling LV to normal LV, or at least you can improve the EF and reduce the hospitalizations of the repeat hospitalizations of the heart failure. So when revascularization is the sweet spot, ideal candidate for the revascularization is in the heart failure with ischemic cardiomyopathy, EF is less than 35 to 40, significant CAD, demonstrable viability, persistent symptoms despite GDMT with 4 pillars of the treatment. So these patients benefit most. So like when revascularization will not help, so extensive scar, no viability, severe comorbidity, advanced frailty, these patients need moreover CRT, LVAD, transplants, not PCA. So I'll be discussing like few cases regarding how the patient is presented with the heart failure, how we manage, and how they at follow-up how the improvement of the LV and all. So this is a case of 65 years male diabetic hypertension, old CAD status post PCA 2011. So now he presented to us with new onset of heart failure, raised troponin levels. So stabilized heart failure with NIV and decongestive measures. So we took up for the lab and we did angiogram. So these are the angiogram findings, which showed the extensive TVD. Ramus and LAD shows the critical stenosis. Mid-RCA showed acute and chronic total occlusion with retrograde filling from the relapse system. So we took up for the PTCA and we did a complete revascularization RCA, and LAD was completely revascularized, and Ramus also we did revascularization. So at the time of follow-up after 6 months, like initially his EF was 40% and it got improved to the 50%. And there is no repeat, there is no admission of the heart failure, admission of symptoms have got worsened with the GDMT, and he is doing good. So this is one of the case like, he 66-year-old male patient, diabetic CAD, set up for CABG 2015. So he used to have a recurrent heart failure admissions in different hospitals, and he presented with us with acute HF with grossly elevated drop. So we did CAG. CAG showed like LAD has a long segment lesion extending from ostium to mid-LAD, and Ramus and L6 are deceased. RCA, there is a distal borderline disease. So we took it for the angiogram and we did basic 90 basal angiogram followed by the graft angiogram. So graft details showed like SVG2OM is the like patent with mild to moderate disease, and but if you can observe, like lima to LAD graft is non-functional and totally collapsed. There is no flow. The lima to LAD flow is not at all maintained. So we took it for the PCA to LAD and we revascularized the LAD segment, which with the flow improved, and the patient improved well, got discharged, and at follow-up, like initially this is at presentation is EF was around 30, and at follow-up is around EF improved to 40, and he is on GDMT treatment with 4 pillars of the medication, and he is doing good. So what are the, like if we would have treated only congestion, we would have discharged with ischemia. So revascularization is like which patient we need to select, which patient to be done, we need to assess, and then we should take up for the care. So what are the recent articles, what we like what it suggests like for the revascularization? There's a revascularization strategy in ischemic cardiomyopathy, few articles which I'll just tell you the clinical impact in implication. So which show like CBG remains the preferred intervention for the eligible patients with multivisual ischemic LV dysfunction. So meta-analysis, what it showed, like suppose the individualized ischemic evaluation, not routine PCA without ischemic evidence. So PCA outcomes in severe LV dysfunction, which showed like PCA should not be routine in chronic ischemic AF, reserved for acute destabilization or refractory symptoms. So revascularization in current concepts of HFrEF supports the integrated approach using imaging, clinical risk, and selective angiography. So the sweet spot of the heart failure management is diuretics treats symptoms and oxygen treats hypoxia. GDMC treats neurohormonal axis, but only revascularization treats the underlying cause in ischemic heart failure, missing viability assessment, missing opportunity to reverse the heart failure. So what are the key take-home points? Like diuretics improve symptoms and oxygen improves saturation, or GDMT like it improves the survival. But only revascularization can restore the myocardial function when viability is present. If you do not assess the viability, we miss the opportunity to reverse the heart failure. The sweet spot lies between stabilization and irreversible remodeling. CABG improves the long-term survival in selected ischemic HFrEF. PCA benefit limited in stable chronic LV dysfunction. So, like, what is I want to end the slide with a strong note, like, not every weak heart is a dead heart. Viability imaging identifies the heart waiting to recover. So, thank you.